for the short presentations. I think it is always a bit difficult to immerse oneself in a health system that's completely different than one's own. And it can feel a little bit dry, right? If you're just looking at numbers and you're trying to figure out, I can't imagine what this health system is like. So what I'm going to do for you is I'm going to upload some short videos, okay? Very short ones. They're about 4 or 5 minutes long. I don't think I have all of the countries represented, but I'm going to give you one for Brazil, for China, and I think I have 2 more systems that are quite interesting. And that gives you a bit of a more visual picture because, as I said, on paper it's a bit dry to really visualize what the numbers mean, right? Okay, so today's subject is really taking us into the first steps in the research cycle, in the health policy and systems research cycle, and we're going to be looking at what this cycle is, what the 8 steps are, from setting a priority, defining a problem, all the way through to thinking about an analysis plan. And then the second thing we're going to be doing is spending a bit of time thinking about how this exercise of priority setting is actually done. So the first thing I'll be doing is telling you a bit about the framework that we'll be using in this course for planning a research study and implementing it. The second bit will be to look at different ways that we can use to set priorities for health policy and systems research at different levels. And the third will be to give you some support in terms of understanding how to define your research problem. So research, I think what's very important to take away from this diagram is not a linear process. And by that I mean that we often start with some theory. Okay, you might say, no, I don't have a theory about what I'm looking at. But everybody has some hunch, some idea at the back of their mind about their topic, right? You don't go blindly into the field. The reason you choose a topic is often because there is already a sense that there is something that's not as it should be. There is some kind of problematic issue, or there is some gap. And you already have some sense of what you might find. So even if you don't think about it as a grand theory, you already, because you're human beings and because we're constantly interpreting situations around us, events, processes, we have some theoretical thinking that's inherent to us. And the theory leads you to pose questions or pose a hypothesis. Often in quantitative research, you are actually stating a hypothesis that can be proven or disproven. But the theory should lead you to questions, okay? So even yesterday when you did your frameworks of the health system, if you went back to those frameworks and you said, how would I ask questions that are derived from this framework, you should actually be able to do that already, okay? Even if they're not very fine or sophisticated, but you should be able to formulate questions based on what you outlined yesterday. From questions, we move to a research strategy. And that strategy usually involves thinking about a design, an overall methodological approach, and maybe a setting and a population. And then we move into the actual methodology, the methods of data collection, the way I'm going to conduct myself in the field. A lot of that is dependent on the type of research you're doing. And then you might have your analysis plan. But after you do some basic preliminary analysis of your data, it may actually lead you to revise your original theory, right? And then you might say, actually I need to go out and do a bit more research. Okay, so in quantitative research, frequently you do not have that opportunity midway in the research to change or shift your questions. In qualitative research, it's very common because you're learning along the way. And so, you might collect some data and you might realize, oh, my questions could be refined, or I need to talk to an additional group of people, and so on. So this process is iterative. It's not linear. So when we think about the health policy and systems research process, we generally think about 8 steps. And here it looks a bit more linear than what we saw on the, in the other diagram, but it is just for the purposes of illustration to show you how we're actually structuring the content of this course. So today we're going into problem identification, and by the end of the day you should have a good idea of what it means to define your research problem, and from that to have a sense, a broad sense of the aim of your research, right? We will spend more time this afternoon and tomorrow framing the issue and formulating questions. What do I mean by framing the issue? What does it mean to frame a topic? What do you think it might mean? Yeah?
Identifying the research gap.
Mm-hmm.
Referring to the existing literature and identifying the research gap leading to formulating the research questions.
Okay, I would say that you're halfway right, but there's something else when I'm talking about framing, okay, which goes back to the role of theory that we saw in the previous diagram, okay? So what does framing mean? So why is it that, let's say we're looking at, again, going back to the TB control example, why is it that this gentleman here, who has experience in TB, is going to frame the problem differently from this table, where you might say, we don't really have experience in TB, but we're going to do some research. So you're going to frame the problem differently. Why is that?
Maybe due to previous exposure, like we got this knowledge, attitude, and practice, like while framing like forming a issue means writing a problem statement. In other words, like you mentioned about TB, the guy has more exposure and he has got insights about TB, how it is working, like at all the level, from clinical to like implementation. Mm-hmm. So it will be very easy to for that person, like which problem we need to give priority more, or which one to be given the first priority, and which one supposed to make or take it as a question for the research, and where the gap, so it comes there. So that the difference in making or framing an issue from a person who is exposed to that any of the field is entirely different for the person who is not at all exposed to that field. That's what I meant.
Okay, good. So the issue, yes, go ahead.
As he has worked in that, he will be giving us an insider's perspective. Mm-hmm. And as a researcher or observant, we will be having an outsider's perspective.
Okay, very nice. Okay, so the main thing is, sorry, I'll just continue. The issue about framing is not so much that he is in a better position to do research, okay? It's not about better or worse. He is more exposed, he has more experience, but that might be a disadvantage. Why is it a disadvantage, potentially?
So, as the ones who don't have exposure,
Thank you. Okay, so as the ones who don't have experience, we would look at each and every angle, mm-hmm. And then decide in which direction we want to go, mm-hmm. regarding a particular issue, while he already knows the weaknesses and the strengths of the TB program, if you're talking about that. So he would naturally be directed towards those parts which he as
okay.
the person involved.
Okay, nice. Okay, so we'll continue along that vein, but the point is that always think about the sense in which your background, your training, your preconceptions are going to shape or frame the topic, and be aware of that, yeah? So if somebody is very well exposed to the TB control program and all the issues, the problems that it may throw up from a programmatic point of view, it means that he has to take extra care to make sure that he's explicit about his position and the way he's framing the topic, okay? Which may be quite different than yourself, okay? Because your starting point is different. You're going to say, I'm interested to understand why TB workers are not happy with their jobs, because why is TB undervalued or something as a area of work or whatever it is. Okay, but the starting points are different, but we'll get into that. Okay, so framing the issue, we then move into study design tomorrow, and then we'll be doing some work in terms of thinking about methods and methodologies at different levels of the health system, and then moving into some tips for analysis and interpretation of your data and knowledge transfer. So health policy and systems research has a very specific focus on policies and systems, but it actually borrows its methods and approaches, we've already said, from very different disciplines. And each discipline has a different way of doing research. So again, you can come at it from the point of view of your own personal work experience and think about the questions that the topic arises for you, but it also, you can come at it from different disciplinary perspectives. So I recently examined a thesis which was about the history of the DRTB program in South Africa, and this person took a historical perspective, trying to understand how the history of apartheid, the very racist policies of the apartheid government, how it impacted on labor migration patterns and in turn fueled the drug-resistant TB epidemic. So they were looking historically at what had happened and how the program was responding to those particular emerging challenges. Now that's a historical perspective, but if that person had been a geographer or an anthropologist, they might have started from a different interest, right? Researchers develop a shared understanding of the discipline, which is called referred to as a paradigm, and a common way of doing research methods. So often, if we're trained in a certain discipline, we tend to work with a specific paradigm of research. So we're going to explain what paradigm means. But the structure of the research process is common. So it doesn't matter what paradigm you're using, but essentially you're still using these steps. So we're going to come back to the issue of paradigms, this I think a bit later, and I'll explain that a bit more. But let's start with how we identify the problem, okay? So this step is as much about the topic of investigation as it is about deciding what merits research. Because when you choose to do your research, whether you're a PhD student or a master's student, or whether you're somebody who's commissioned to do a piece of work, you want to ensure that what you're doing is actually valuable, that you're not replicating work. You're not doing something that has already been done. And so you're going to do a lot of background research to find a question that's novel, that's interesting, that's unique. Now, obviously, at a master's level, nobody's going to demand of you a novel contribution to theory. But still, for your own sake, you would like to have the sense that you're doing something that is valuable, relevant, and maybe a bit original in some ways, right? So this step includes usually a situation or a problem analysis, because you want to see this problem that I'm looking at, how can I understand it from my unique angle? So who decides which topics merit or need research? Yeah? Who makes that decision? You probably won't make that decision on your own if you're looking more broadly at a bigger project, but you might say, okay, let's look at the field and let's see who are the people who are setting the agenda. Are they policymakers? Are they technical people? Are they technocrats? So going back to the topic of the regimens, the drug regimens, it could be that the research agenda is being set by the pharmaceutical companies, right? Because they want to know and they want to get their drug as quickly as they can onto the market. So the agenda setting is happening at from a very powerful lobby. Are they service or program managers? Okay, so if you're from a pharmaceutical company and you're from the program, you're a program manager, your starting point for the research will be different. Your timelines for the research will be different. What about politicians? What interests do they have in funding or commissioning pieces of research that are going to shed light on them favorably, right? Funders, okay, we know that in many parts of the world, the research agendas are very much dictated by funding, donor funding priorities. And when the donor funders mix with politics, like we've seen under the US government, it has severe consequences for what gets funded, or indeed what doesn't get funded at all. So at the moment, as you know, we're in this funding freeze from the US government donors. And this is unfortunate that this is all the way at the bottom, but the question of whether the beneficiaries, your clients or your citizens or the public, to what extent do they set the agenda? They should be setting the agenda, because they're probably the people who are most responsive to the services or the interventions, and they should be benefiting the most. But very often they are kind of at the bottom of the list, because they don't have the voice or the power or the authority to really articulate. So we pay some lip service to community engagement in research priority setting, but the reality is the research priorities are not generally, unfortunately, not really set at that level. We try to do it to some extent, or we look for ways to do it, but that's another topic. Okay, so the research priority setting process, which I'm going to describe a little bit, is really to ensure that the best use is made of available resources from an equity point of view. Health research is based on this idea of the value of equity, and therefore you need to employ a really systematic approach to setting priorities, because health is something that is considered a public commodity. It's a public good, and therefore the decisions that are taken about where I allocate funding for health research need to be taken in a fair manner, in a way that is, in a just manner, and so on. So we're talking here about health research more broadly, because there's a lot more information and research, or rather studies about how priorities in the health sector are set than in the health policy and service and systems research. So you have to think about identifying human and financial resources required, planning, amidst competing and overwhelming demands. The other aim is to strengthen the links between research, action, policy, and practice. And this priority setting really happens at different levels. It happens at a global level, it happens at a national level, sometimes it happens within a specific discipline or within a specific institution. So the Department of Health Sciences here probably sits down and sets some priorities in terms of the research topics they want to pursue. And they may not have a lot of freedom there, because they're very contingent on the funding that's available through ICMR or whatever. But they will still nonetheless make a decision based on the strengths, the expertise of the department, the interests, about what they would like to pursue as a research agenda. So it's acknowledged to be a key function of national health research systems, and it's a very important process, because you have to align your research funding with evidence needs. But priority setting, the reality is, for health research is often not really performed particularly well, and sometimes it's not performed at all. So the reality is, in many low and middle income countries, the research priority setting exercise was not particularly well developed for a very long time, until the mid-90s. So this is a quote from a study, and I should have provided you with the reference. But this is a study that was done by Kent Ranson back in 2010, I think, where he's citing a survey by the World Health Organization of more than 550 policymakers and almost 1,900 researchers in 13 low and middle income countries found that about a third of policymakers, researchers, and users of research interviewed said that there was no rational process to set health research priorities in their country, or that they were unaware of how those priorities were identified or set. So that's quite alarming. So there's actually the reference to that paper. It's Ranson-Bennett, Priority Setting in Health Policy, and systems research. So thinking about health policy and systems research priorities, when it is a difficult field to situate within the general health research priority setting. Because when you're thinking about health research priorities, you're often thinking specifically about things like disease burden, right? How severe is it? What is the impact on the economy? What is the impact on people's livelihoods? Whereas health systems and policy research priorities are more about what is functioning or not functioning in the system. So we cannot really use the same principles that we use for setting health research priorities for health policy and systems research priorities. Because if we do that, for example, if we look at health policy and systems research issues through a specific disease lens, for example, trying to establish priorities in malaria or HIV or NCDs, the priority exercise becomes more technical versus interpretive in nature. It's driven by the disease burden and often focused on understanding how high that burden of disease is and how it can be averted by developing new drugs and technologies or improving whatever we have or extending the uptake of existing interventions. So these 2 points definitely are not about health policy and systems research, right? They're about changing drug, as we spoke about this morning, about changing drug regimens or coming up with new drug regimens. Extending the uptake of existing interventions could be implementation research, but otherwise that's it's quite limited. But on the other hand, when you think about a health policy or a systems research priority, sometimes when you're thinking about the system as a whole. So therefore, if you're trying to decide on priorities for malaria control, you have to think more broadly. How is this going to impact on the rest of the system? If I pour money into HIV, does it mean my other services in the system are going to be underfunded and less able to deliver their interventions, which is exactly what happened, right? In the years where there was so much money pumped into HIV that the rest of the system got weaker in many countries. So health systems research question may provide benefits or may have unintended negative consequences for multiple other diseases. So here the argument is that if you link health systems research questions only to specific diseases rather than seeing them in totality, it results in those topics being deprioritized, resulting in a kind of fragmentation of systems research. Okay, let's just look at the kinds of organizations that are doing health policy and systems research setting and that are trying to overcome the kind of challenges of using the sort of normative frameworks that are used for health research setting. So there is something called the Global Forum on Health Research, which was established in 1988. So this is actually for health research, but they have tried to take health policy and systems research more into account. And it's essentially demonstrating the essential role of research and innovation for health and health equity to benefit poor and marginalized populations. It's trying to facilitate the definition of global research priorities in health, which is a huge exercise, because as soon as you move into the global realm and you recognize also that setting priorities in one country without thinking about the country next door is also an issue, right, with globalization and cross-border movements, etc. It's trying to stimulate coherence between actors involved in health research, and it's trying to strengthen the use of evidence in decision-making. So these are some of the considerations that are relevant. We need to think about the way in which priorities can be set at a global, national, subnational, or institutional level. We also need to think about comprehensiveness. So some priority setting processes will focus on narrow questions. So for example, key research questions for malaria control. Others are going to set questions for the whole health sector, right? There is, I mentioned this word before, the technical versus the interpretive. Okay, you might say, what does that mean? What exactly did you mean by that? So processes within the health sector can be predominantly technical. So in other words, they're dominated by quantifiable needs or cost data, which is a technical approach to setting priorities. or they can be more interpretive, which means I want to gather consensus, yeah, from a group of people who I consider experts. Okay, I'm going to bring together a group of people who have a good idea about what the priorities are, or what are the needs really before the priorities. What are the needs? What are the needs? What is the evidence for those needs? What is the evidence on the cost effectiveness of interventions for those, addressing those needs? And I'm going to gain agreement or consensus. Okay, that's a different approach from a purely technical approach that just goes on cost data or cost effectiveness data. The fourth point is that who am I including in my group of people who are involved in the research priority setting process? So those included in a consultative process could be primarily researchers or experts in the field, or they could involve funders, research users, or communities. So this is also a very big decision. So if you consider each of these points, when you think about priority setting exercises, even at a small level, I think these are worth considering. Okay, what kind of evidence am I bringing into the equation? What kind of people am I going to consult, right? And am I looking at a more technical form of evidence, or am I looking at interpretive evidence? And at what level am I setting my priorities? So, yeah, I think we've said this one already. We've said that if we looked at HPSR through a disease-specific lens, we would result in a situation whereby we have a fragmentation of the health systems research, and what we really need to be doing in terms of HPSR priority setting is emphasizing health systems challenges. So back to the building blocks in some ways, the governance, the financing, the service delivery, and the roles of specific actors within the system. So this is another forum which is called the Health Research Forum, which in the 90s produced what are called the 1090 reports, which was essentially stating that 10% of resources worldwide devoted to health research were put towards research on health in LMIC, whereas more than 90% of preventable deaths occur. So basically it was highlighting this huge imbalance in terms of where the resources for the research were going. And it's not so surprising, right? Because you can imagine those high cost, very highly technical, very high, biomedical types of interventions, very sophisticated interventions are also going to be the most costly in terms of research. Whereas research that involves low cost, acceptable, low tech interventions are going to be less expensive. But it's still a shocking fact that only 10% is spent in countries where you have 90% of mortality that you could be prevent. So as a result of this quite alarming report, there were efforts to develop more rigorous research priority processes in LMIC. And this forum intended to provide impartial evidence, practical tools, and intelligence for informed decision making. So this was happening around the 90s. It was also conducive to fostering some networks, coalitions, communities of practice, which would lead to solutions in terms of how we would go about this exercise, and really trying to advocate for changes in priorities, resources, and policies. So what was also happening in the 90s is attention was being drawn to the fact that the research priorities for low and middle income countries were mainly being drawn up in high income countries. And so there was a real imbalance in terms of not only the research priority setting process, but also in terms of the research that was being produced, and the imbalance in terms of low and middle income research produced in terms of publications and things like that, okay? So in 2010, this Global Forum on Health Research was absorbed by something called the Council for Health Research for Development, which unfortunately subsequently suspended its operations due to financial circumstances. So that's just to mention that if you look it up now, you'll see that it no longer exists, but there are some other organizations which continue to do these exercises. One that we've mentioned yesterday already is the Alliance for Health Policy and Systems Research, which was set up 1999 and hosted at WHO. And they also, although they're not explicitly a research priority setting agency, but because of their importance in the field of health policy and systems research, they tend to set the tone. They tend to commission small pieces of research, and they define topics of interest. So whenever you want to see what are kind of globally, what are some of the key health policy and systems research topics or the agenda, it's worth going onto their website and looking at, you know, recent calls, recent reports, and so on. So they promote and generate the use of HPSR as a means to strengthen health systems in low and middle income countries. It's a unique forum for health policy and the systems research community. They're involved, I think, in hosting the health systems global meetings, which happen every 2 years, and which are a very important place to both, you know, to gain more knowledge about this field, but also to network. They support institutional capacity for conduct and uptake of health policy and systems research, and certainly in the early years, they tried very strongly to set up South-South partnerships. So they would have researchers from Kenya coming to India and researchers from Uganda going to wherever other countries. So there was some stimulation of the idea that actually local researchers who were close to their health systems were in the best position to conduct some of this research. And they stimulated generation of knowledge and innovations to nurture learning in health systems, increasing the demand for and the use of knowledge for strengthening health systems. So these are some of the reports that came out of the Alliance. We've already mentioned the systems thinking report before. The one on the far left is the reader, which is freely available. As you know, you would have looked at the first chapter, and the whole book is actually, it's a reader that I participated in many years ago. I think it's 2012. And it offers not only a narrative account of different types of research that are contained within HPSR, but it also offers you very good examples of papers that use a particular research methodology and a particular framing. So these are some of the other examples. There was one on, oops, it's not working. That was one on human resources for health that was produced a few years later, one on medicines. This is a fairly recent one, I think, the participatory action research one in health systems. And that is a topic that we'll also be taking you through in the course of the lectures. Okay, let's move to national level priority setting processes. So before 2010, priority setting processes for HPSR relied on relatively limited consultative processes, which took primarily place at a global, at an international level. And after 2010, there was really emerged a strong rationale to use country priority setting processes to inform global priorities. So it was kind of seen in the other way, that actually national level and even further down should be informing the global rather than the other way around, right? And these approaches often combine expert input with stakeholder engagement. So these are some of the methods that have been used, which you may have heard of. And they're essentially methods that attempt to generate a consensus. And a consensus simply means agreement across a group of experts or stakeholders. Delphi method is one method. The nominal group technique, which involves structured small group discussions where participants generate, they discuss, and they rank research priorities. But there's also been the attempt to include more participatory approaches, where policymakers, frontline health workers, and communities are engaged to identify pressing health systems challenges. Other interesting examples include things like citizens' juries. Okay, so a citizens' jury is almost like you know what a jury is, right? Where you bring in members of the public, citizens, to participate in legal decisions. A citizens jury is a common, well, it's maybe not that common, but it's a form that is used in the UK. And for example, there was a deliberation some years ago about the use of patient records in research. And they had a citizens jury where across the country they had stakeholder meetings with members of the public to debate this topic. And you might say, well, how do you involve members of the public in something that seems kind of technical, the use of patient records? But I think the whole point is that the whole process, the deliberative process that led to the inclusion of members of the public in this was a really important one in terms of empowering people to have a say. Crowdsourcing is another kind of thing. Crowdsourcing is often thought of more as a media thing, as a way to generate creative ideas, etc. But crowdsourcing can also be used to gather opinions on what people think is the most pressing thing that should be dealt with through research. Okay, so crowdsourcing happens a lot in Europe. I mean, I'm constantly getting things through the mail from the council of the city where I live, which is saying vote on the new design for the park near the train station, or vote on the new, it's usually around urban infrastructure, but it has been used also for things like ideas to improve accessibility of people to testing services for something, or screening services, and so on. Okay, so at national level, there is something called the Essential National Health Research Framework. And again, this is not specific to HPSR, but it is a national level framework. And that was developed by the council that I mentioned before. And they essentially rely on two different forms of knowledge to inform the research priority setting process. One is an evidence-based situation analysis. So in order to set priorities for the health sector, they would want evidence on health status. What are the main problems? What are the common diseases? What is the burden? What do they mean for people's morbidity, mortality, for their quality of life, etc. And they also collect information on the health system. So the current status, the current capacity, capabilities, deficiencies and problems, and the health research system, which I think is also an interesting point. So the capacity of the health system itself to engage and produce research. So is there capacity, is there funding, is there allocation, is there experience for people within the health system to be able to be reflective, to look at the data that is coming out of their system and analyze it? Because we know in many health systems that are underfunded, you have vast amounts of data and nobody actually gets a chance to look at it or make decisions based on that data. And so I remember working in Pune, as I said, more than 20 years back, or less than, I don't remember exactly now, it must have been 2006 or 7, and Abhay will remember this, that we worked with a particularly, a very enterprising TB control manager who was interested in research, and he himself wanted to work closely with us to start looking at data within his system. And we wrote up that process because we found he was rather exceptional in terms of his dual role as a program manager, but also as somebody who wanted to do research. And often that's a luxury because you don't have the time to do it unless you step out and do a master's degree or something, right? The other thing, so we said evidence on the one hand, but the other thing is setting selection criteria for the use of that evidence. So every time you have a research priority setting process, and even when you're sitting around a small table and saying, okay, we have this, as master students, we have this opportunity to work on a project, or we're affiliated to a specific bigger project, you are still going through a couple of questions in your mind or in your team to set priorities in terms of what you're going to do. And one is whether it's appropriate. Should we do it? Now you might say, what do you mean by appropriate? Is it appropriate to the setting? Is it something that should be done from an, is it okay from an ethical standpoint, for example, right? Is it something that it fits the interests of the program you're working with? Yeah, so that is a bit different than relevance, because it is more about aligning yourself with your stakeholders, your local stakeholders, or the people that you're working with, your target population. The second point is around relevance. So why are you doing this? What relevance does it have? Now, this is a big point of contention, okay? Why? Because the TB control manager versus the anthropologist are going to say the work has different relevance. Not every piece of research has to have direct applied relevance. So I remember when I first started lecturing years ago on the use of social sciences in public health, at a time when there were not so many anthropologists bridging that gap. And I remember people would always come up to me with, charged up and say, but don't you want to save people? Because they felt that some of the research that we were doing as social scientists didn't necessarily have a direct impact on the lives of people. And I would say, no. What about philosophers? What about economists? I mean, not economists is a bad example, but what about people that want to understand behavior? They want to understand practices. They want to understand how people think about things purely from a theoretical point of view, okay? So again, it's a contentious issue. You might say, as people working in public health, but as soon as you move into the realm of public health, you have to think about, or health more broadly, you've got to think about your research as having application and relevance to improve the situation, improve the health of people. Whereas many social scientists would say they're conducting research not directly to improve the lives of people, but to better understand why people do things the way they do. Yeah? So I think this question of relevance, especially when you're in a mixed disciplinary group, like I showed you the example yesterday, is always going to be a big discussion. Yeah. The next is, can we do it? So that's a kind of a basic question, but you might not think about it, is that sometimes we set a research project and we realize, given the time available, given the skills set, given the appropriateness of how it fits in, I want to do research in clinics and I want to observe consultations, mental health consultations. You think, is that really feasible, ethically, practically, morally, etc., right? So that's feasibility. And impact is really, again, tied in with relevance. So relevance has to do with, is the topic important and of relevance at a certain given moment in time? And impact is what difference is this research going to make? And again, the stakeholders might be different. Your historian or your anthropologist might say, this is very relevant because this is going to shed light on the historical injustices that have been committed against people who are of a different ethnicity, etc., right? That's the impact for them. Whereas somebody else is going to say, this is going to make a difference because I'm going to be able to show inequities through numbers. I'm going to show you that people who are of X ethnicity are less able to access the system and as a consequence are suffering a higher burden of the condition. Okay? So I'm not going to set these in stone, but always try to think about where am I coming from, what is my interest in this research, and apply that across the board in terms of your questions. So on the right is just a bit of explanation around that. So we're thinking about benefits, issues of affordability, efficacy, effectiveness, equity, coverage. Those are very classic public health or health research questions. We're thinking about issues of the technical, the economic, political, sociocultural aspects when we think about both relevance and feasibility. What are the community concerns? How big is the problem? How severe is it? Does it respond to national health policy and equity focus? And then we're thinking about the issues of acceptability. Some of the questions are outlined there. So I'm going to give you an example. I looked quite long and hard to see if I could find a description of a national level health policy and systems research priority setting exercise. And it wasn't very easy. There are not many good documentations of how people went about this. Ethiopia, as an example, stood out. And I have to say, Ethiopia is interesting. Every year in Antwerp, we get lots of Ethiopians on our health policy and systems research course. So they're really making a concerted effort to bring health policy and systems research into their public health, into their health research curriculum. And they're also involved in quite a lot of innovation in terms of priority setting exercises. So countries like Ethiopia, which has been one of those countries which is known as the good health at low cost countries. I don't know whether that's still true because of the political conflict which is undermining the system, but it is one of the countries that was for quite some time seen as a good example. Obviously face resource scarcity, and basically the less the health budget, the more you need to think about, good criteria for which you're going to use for allocating resources properly. It needs to be critical, it needs to be evidence-based, and so on. In Ethiopia, performance of your key health variables and your progress towards universal health coverage is still low. Lots of challenges, including poor resource allocation, lack of evidence-based decision, weak public-private partnerships, weak intersectoral collaboration, and weak collaborations of academia, so researchers and policymakers. So as in many LMIC, for a long time, HPSR studies were not the primary focus and often led to decisions in the health system that were not based sufficiently in evidence. Yeah. So this is just, we can look at the paper later, but this is what they did, and it's just to illustrate the process. And basically, it's a consensus generating exercise. So they first, in phase 1, they selected participants, and I think they had a mix of participants representing, health stakeholders, but also community stakeholders, I think a number of intersectoral stakeholders as well. And then they had to set and reach consensus on what were going to be the criteria for prioritizing. Yeah? So we had some very general criteria before, which was relevance, acceptability, et cetera, but they took a lot of time to think through the criteria. And then they basically used the building blocks as a framework, and they added on health policy. And they then grouped their stakeholders according to the building blocks. So people who had more expertise on the health workforce, people more on health policy, and so on financing. And so within each of the building blocks, they then had to do another exercise where they set priorities within the respective fields of the health system. And then they held workshops to rate, rank, and build consensus on the identified topics. So it's quite a lengthy process, and you might be saying, well, nobody's going to have the time. How would you do this exercise in a short amount of time to reach consensus? So this is a good question, right? It's a practical question. I'm just going to show you the way they set those criteria. So in their case, it's a bit difficult to read, but the first criteria was the impact on health. What is the potential for the research findings to impact population health? Yeah. The second was relevance for policymakers. How much of a priority is this question for implementers and policymakers? The third was workability, likelihood to answer the question using routine or survey data health sets. Okay, so they basically said that our research priorities have to include this criteria of whether the research endeavor is actually feasible within the normal working lives of health program managers. Feasibility, how feasible is it to research it from a cost point of view and an ethical point of view? Availability of evidence and originality, so you don't want to duplicate work that's already been done. And practicability, so is the research result likely to be translated into health interventions or program actions? Okay, so they had to they set the criteria and then they actually weighted the criteria. And weighting means that some criteria were given more emphasis than others. Oops, sorry. Okay, so that's just an example of national priority setting. And I think now we're going to move to thinking about defining the research problem. Okay, so the priority setting is, as I said, we've talked about at the national level, at institutional levels. You can even think about it, you know, setting, you will see, for example, specific forum that are set up topic-wise. So what are the priorities for looking at gender-based violence, or what are the priorities in HIV prevention? And usually, I think you should all be critical, you should be skeptical, you should say, how did they reach those priorities? What was the exercise that was undertaken? Okay? What criteria are being used? How are those criteria being weighted? Who is being involved in this exercise? So next time you see that, you know, India has set X, Y, Z, or my institution has set these priorities, be critical. I mean, obviously don't risk being thrown out of the institution, but certainly question the processes that lead to some topics being on the agenda and not others. Okay? So now we're moving to defining the research problem. So research priorities, we said, they might set the agenda in general. Okay? They set the agenda for funders, they set the agenda for institutions, they set the agenda for individuals in some way too. But a strong study begins with a well-defined problem. And usually we can think about two types of problems. So sometimes it's easy to think about a problem as basically something that isn't as it should be. That's the most simple definition. Yeah? You have a situation, you know that, you know, your malaria control program is supposed to reach so and so many people, but this isn't the case. So that's the problem, right? Or your new guidelines for XYZ screening are in place, they're accessible, but they're not being used. That's the problem. So it's usually a gap. It's a gap in terms of the policy, which is not reaching the local levels, or it's an implementation failure, or it's inequities, for example, in terms of people's access. But sometimes it's not so easy to define a problem because you just want to fill a knowledge gap. So the problem is just the knowledge gap. Yeah? There is not enough known about this issue. That's your problem. Okay? So there's two different ways of contrasting. So often a descriptive study, or which is lacking, you know, description, lacking information on the burden, the prevalence, the severity, is also a knowledge gap, which can be also seen as a problem. So how is the policy being implemented in practice? So I've instituted a new free maternal health care policy, and I don't know enough about whether it's actually increasing uptake. The problem there is not knowing what impact it's having, right? But if I said I've implemented my free maternal health care policy, I have documented that women from these particular castes are less likely to access the system, that becomes the first type, yeah? So the issue is not as it should be, because we aim to extend universal coverage of these services across the board, but we are seeing in our numbers that so and so many women are not attending, and they all happen to be from more disadvantaged groups. So in health policy and systems research, we're not just talking about practical or operational challenges, but issues that can be researched. So as we said, a knowledge gap, for example, would be, we don't know how private providers are managing diabetes in a low income setting. That's a descriptive gap, yeah? We don't know about their management practices. So your researchable issue is, how do private doctors diagnose and treat diabetes in an underserved area, right? It could be a policy implementation gap, like we said. So the example I just had, despite free maternal health services, poor women are still having low access. Why is the policy failing, or what are the barriers? That's your implementation gap question. Or it could be a systems challenge. So despite government incentives, whatever financial or non-financial incentives to, attract people to work in rural and remote areas, there's still a shortage of doctors in rural primary healthcare centers. So your issue is, what factors are influencing doctors' decisions to take up or to reject those rural postings? Okay? So always remember this. It seems like it's a very basic point, but you cannot imagine the number of thesis topics that I review every year which are not problem-driven. So you've got to have a problem to start with, right? Okay. We're going to move into a little exercise. So I'm just wondering whether we should interrupt the recording, but I'm going to just briefly show you something here. So this is a fairly recent article from the UK Guardian, and you can just read it through. Africa's medical system risks collapse in the next few years, warns health leader. Health services in Africa are at risk of collapse in the next few years due to soaring chronic diseases. A senior public health leader has warned. Foreign aid to Africa has been focused on infectious diseases, leaving conditions such as cancer and diabetes to escalate, says this leader. In sub-Saharan Africa, NCDs accounted for 37% of deaths, and so on and so on. They're forecast to become the leading cause of death. Aid is not charity and will inevitably follow donor countries' own interests, etc., etc. Okay, I want you now to tell me what the problem is here that would drive your research. So there's different problems that are looked at. So you can tell me all the problems you spot here, and then we're going to talk about which one leads you to a health policy and systems research question. Okay, anyone? So there's a couple of different things hinted at here, right? So what's the obvious one?
Focus on the infectious diseases, neglecting or under prioritizing the NCDs, causing a rise in deaths caused by NCDs.
Okay, good. So that's all you need to say. So focus on infectious diseases and a neglect of non-communicable diseases. What is another problem, even before that one? Yeah? Go ahead.
Lack of funding for NCDs and more funding allocated to infectious diseases.
Okay, that's similar, very similar. But even before that, what is the big problem that jumps out? Yeah?
The dependence on foreign aid.
Good. Okay, dependence on foreign aid. But even before that, before the dependence on foreign aid.
The system focuses on mostly on infectious disease. So
Yeah.
if the transformation is there from non-communicable to communicable to NCD, the health system is not ready to take it.
Okay, good. Okay, so you're coming up with similar things, but the first problem that you notice is NCDs are on the rise, right? Descriptive problem. Is that a health systems problem per se? Okay, what would make it a health systems problem? How do you look? Okay, if I tell you NCDs are on the rise in the continent, sub-Saharan Africa, what is your health systems question? Simple question.
Whether the health system is prepared for tackling the increased rise of NCDs.
Absolutely. Health systems readiness to take on the burden of this rise, right? Or what are the implications of the growing number of NCD cases for the health system? That's a basic question, yeah? But what is a deeper question that is immersed in here? You've noticed, you've got two other questions. So one that you raised and one that you raised. So 2 or 3 people mentioned the difference between focus on infectious diseases versus NCD. So what's the question there? What's the problem that leads to the question there? Yeah, go ahead. You mentioned you had that one.
Just thinking out loud, could it be a high prevalence of infectious diseases as well as high prevalence of infectious diseases, existing high prevalence of infectious diseases leading to the health systems focusing on infectious diseases surpassing the NCDs?
Okay. Say that again, sorry.
It's what to prioritize, whether the increased burden of NCD that we have to address or the ongoing infectious disease which is already creating a lot of morbidities and mortality.
Okay, good, very good. So both of you are on the right track, but just push it a bit further. How would you put it in terms of a nice macro level question?
Are there any policies which are existing which is planned or a roadmap to reduce the NCDs or the infectious disease?
Are there policies to what?
To reduce the how the system will be going to be readiness for the increasing NCDs. So whether the
Okay.
policy is existing or not.
That's not what you said before. Your starting point was infectious disease versus NCDs. So what is the systems question there? Yeah, go ahead.
Maybe about how can resources be allocated to managing both the issues like simultaneously.
Okay. Even more basic is what resources are currently being allocated for infectious versus non-communicable. Okay? So sometimes don't make it too complicated for yourselves. Think, the first thing I'm seeing is a rise of NCDs. What implications do they have for the health system? What do they mean in terms of organizing the service delivery? What initiatives are there to respond to this burden? What is the health workforce doing, et cetera, et cetera? Do they have enough training? Then you have the thing which is implied, which is infectious disease burden coexists with NCDs. So I want to understand at the moment, what is the relative prioritization of funding, health workforce, service delivery models for infectious disease versus NCDs? But another question implicit here, I mean, I'm pushing it a bit far now, could be around to what extent is there any integration of NCD and ID services? Yeah? Okay, but let's come back to this gentleman. He's making a critical point, which you have hinted at, but you haven't yet told me. What is his point? What is he saying here? Read the last paragraph.
Like he is mentioning aid is not a charity and will inevitably follow donor countries' own interests such as stopping infectious disease. Like some of the donor countries countries they are giving money, like just because they are interested in infectious disease, that doesn't mean that we need to go for that. It's not a charity. It's out of global interest, global health interest they are giving. That's what he is trying to say that. And also, like in the first statement, it's like there is a soaring chronic diseases. We may need to think why there is an increase in chronic diseases. As they mentioned, like it may be NCD or anything. Why there is increase before that may be our research question. Of course we know that Africa is more prone to infectious disease if we look at the history. Maybe the reason the donor countries are more focusing on funding for infectious disease prevention. But that doesn't mean that Africa is not at all having NCDs. There is a growing NCD in Africa also. So the donor countries and the health policy makers of the same country need to think where to allocate the fund And like if we come to say, like we can look at the mortality and morbidity, like which disease is it NCD causing more mortality? Or
Okay, but now you're moving off health systems.
Okay.
Yeah, because if you're measuring burden, prevalence, all that, that's not a health systems question. But what I'm getting at is the fact, which you've already raised, is that his critique is essentially to say that this emphasis on infectious diseases is not just because Africa has so many infectious diseases, it is the global biosecurity concerns which are driving the agenda. So there's a lot of focus on infectious diseases because rich countries are nervous about diseases coming into diseases crossing borders. And so his critique is actually about the fact that within countries, within African countries, the research agenda should be driven by what is very obviously now a growing burden of NCDs, as opposed to towing the line, which is where all the money is put into infectious diseases. Okay? So always be mindful of the fact that even when you read, what I wanted to do is I just wanted to show you that by looking at a simple media article like this is a media cutting, it already can give you a lot of ideas, right? Because you can see, okay, there's a lot of things being touched on. There is something around the impact of NCDs and IDs on the health system. There's something about inequities in terms of resource allocation. And there's something about the macro level donor funding priorities that are being set and how they are skewing local health systems. Okay? So there's already 3 or 4 questions in there. All right? Good. Okay. We're going to stop this session soon, but basically, when you're thinking about problems in health policy and research, you are always trying to address an issue within the health system rather than, as we said, a narrow focus on effectiveness of a clinical intervention or burden of disease. You're thinking about systems levels implications. You're sort of examining how different components of the healthcare system interact and contribute to your issue. And often you are thinking about a specific group of stakeholders. So you often will say, I am thinking about, you know, why stakeholders at the donor level, you know, where are they setting priorities in terms of funding for African health systems? Okay, because you could do some very interesting work on that, right? You could take a critical approach and you could say, how are these agendas being set? Why are we not focusing more on NCDs, etc.? So those are basically 3 things. Okay, now we're going to move into a break, and we are going to do a little research priority setting exercise ourselves. So this is where we will stop the recording, and we will move into a half an hour of, I hope, tea, possibly tea or coffee. And then what I'm going to ask you to do is that in your groups, I'm going to ask you to think about health research priorities in India. Okay, I'm not saying health policy and systems research because I think that's too complicated to do right now. But I want you to think about the health research priorities. I want you to create a list of up to, oops, there's a number missing there, up to 7 health research priorities in India. And I want you to make notes on where there is consensus in your group and where there's disagreement and why. And then I want you to think about how is your background or your experiencing influencing what you think should be a priority. Okay? If you had to rank this list, what evidence would you use? What criteria would you set for ranking it? And where would you get the evidence from? Okay, so it's kind of a lot of questions, but actually it's hopefully doable within 20 to 30 minutes. And this is your bonus question. Once you reach consensus on your top health research priorities, how would you start thinking of health policy and systems research priorities within those health topics? Okay, but I think these are the main ones. So we'll stop there. Thank you for your attention so far. And hopefully this will be an interesting exercise that complements the last exercise. And we're now moving into research paradigms. So What we did earlier was we looked at how we determine research priorities, because we want to make sure that our research topics are aligned with priorities. But we actually saw in this exercise that it's not so easy to decide on priorities, because we have different starting points in terms of reaching a consensus on what those priorities are. And that kind of exercise magnified at a level of where national priorities are set, you can imagine requires a lot of deliberation and a lot of time, which is why, unfortunately, not many countries go through that exercise in a very systematic way. So I think this is very, very important. When you look at lists of these are the research priorities in our health plan, look at them critically. Ask, how did they reach those decisions? Okay? Good. So now we're moving into what is referred to as research paradigms and the role of theory. So you have thought about problems and how to define problems. I gave you some tips already. We'll be working a lot more on that as we move into the case studies. But now we're going to actually think a little bit more about how our disciplinary background and our theoretical understandings of the topic influence the way we ask questions. And we're going to talk a little bit about theory more generally. So what exactly is meant by a research paradigm? Yeah, you probably have heard the expression in your studies. People will have talked about paradigms. And it's never, again, it's not a very easy term to think about, because a paradigm, sometimes people think about it as a model, sometimes they think about it as a theory, sometimes they think about it as a philosophical position, how you think about the world, how you view reality. So I hope to shed some clarity on that. Any kind of research is influenced by the researcher's understanding of reality and how to assess it. Yeah? So even if you say, I'm a quantitative researcher, I only do numbers, you still have that assumption that you can measure the reality through numbers, which is already, even though you might not say there's a theory there, it is a theoretical position, because you're saying that this reality of whatever health condition you're looking at or whatever phenomenon you're looking at can be categorized in a way that allows quantification. Yeah? So what I'm urging you to do is that to reflect much more carefully on the type of research you do, and to be more explicit about how you understand the reality that you're trying to assess. What can be known about it, and what decisions you make about what aspects you can and can't measure. Because you're, let's put it this way, whatever research you do is always going to reveal a partial truth. Yeah? It's never going to be the full comprehensive picture, because it depends on your starting point and what you can measure. So be clear about what you can measure and what you are able to document. So a very interesting definition from Thomas Kuhn, who was somebody who wrote a book, a philosopher who wrote a book called The Structure of Scientific Revolutions, and who talked about the great paradigm shifts in terms of our scientific thinking, from going from an idea of the world being flat to the world, the earth being round, and is still very influential in terms of the way we shift our ideas in scientific understanding of problems. He defined a research paradigm as the set of common beliefs or agreements that's shared between scientists about how problems should be understood and addressed. And the reason why his work was so influential is he introduced this idea that paradigms move. They're not fixed, they're not static. Yeah? So even within the course of your lifetime as a researcher, your own paradigms for approaching your study topic might change. Yeah? A paradigm is the fundamental basis of your research project. Okay? It's the bottom, the underpinnings of the project. It informs your questions, your study design, and your methods. And normally we think about the research paradigm as consisting of three main components. The first is epistemology. So these are philosophical concepts, so bear with me. But essentially epistemology is the nature of knowledge and the process by which knowledge is acquired and validated. So how do we know what we know? Yeah? how is it that, this is why, before in our research priority setting exercise, I was asking you to reflect on why is it that you believe you know that this is a priority? How do you know what you know? Yeah, what constitutes a powerful form of evidence or knowledge for you, and where is that knowledge coming from? But before that actually is ontology. So I should have started up front. So ontology is the nature of your beliefs about reality. So what is reality? Yeah? What constitutes reality? The epistemology is, how do I grasp that reality? How do I know what I know about this reality? And then the methodology is your theoretically informed approach to the production of data. So how do you go about acquiring that knowledge? So it sounds complicated, but essentially, if we think about it from a very practical example, let's say that you were looking at stress in, I think you mentioned ASHA workers a number of times, okay? Levels of stress in ASHA workers who are burdened with multiple programs that they have to deliver, okay? So your question, or your ontological question, is that you're first trying to understand the concept or the construct of stress. What does stress mean for this particular group? Yeah? The ontology is around what is the reality of this construct? What does stress mean? Yeah? What is the construct? How do I define it? How do we know what we know is what are the assumptions that inform how I'm going to assess stress? Okay? So if we ask the 5 tables to think about how you would go about capturing the reality of stress among ASHA workers, I can bet you that you would come up with quite different ways of doing that. Okay? Now you probably are more used to starting here, which is that you think about methods. You think, okay, I'm going to go and do a survey, or I'm going to go do some qualitative interviews, or I'm going to observe their situations. I'm going to accompany them as they go, on their daily work practices. And I'm going to assess to what extent I notice that they're coming into stressful situations. But actually, you need to go a step back, which is to be clear that through methods are already quite a step far along. You first need to decide what is the construct, what is the reality you want to look at, and what kinds of knowledge do you think are worth documenting in order to be able to say something about stress in this group, and then you go to the methods. Okay? So a research paradigm actually consists of these 3 components. So we're going to talk about 4 key paradigms in health policy and systems research. And this is based on years of teaching both qualitative research, where we talk a lot about research paradigms, but also teaching both at my former institution as well as ITM in Antwerp, and looking more into the paradigms that specifically shape health policy and systems research. So the first paradigm is the one that you may be most familiar with, which is a positivist paradigm. And again, because of lack of time, I have to caricaturize these paradigms a bit. Normally we would take a week of a course on positivism, or a week of a course, but we don't have a week, we have 10 minutes. So positivism is essentially when you say everything is measurable, everything exists independently of the observer. It's stable and it's cohesive. I pick up this pen, the reality of this pen is something I can measure. I can document the size, the texture, the material. All of this can be captured through objective measurements. Okay? Because everybody would agree, this is not a pen, but this is a pointer. Yeah, it's a laser pointer. Okay? Your positivist doesn't spend a long time deciding, is this a pointer? Is this a pen? Is this a plastic object? What is it? They're not going to think about the ontology of this object, right? They're not thinking about the meaning. They're thinking about this as an object which can be captured through some kind of methods to say, okay, let's assess, how many of these pointers do we have? I mean, sorry, this is a silly example, but you get my drift here. For the positivist, the reality of what they're trying to measure is driven by natural or fixed laws and can be described objectively through empirical research. And that requires that you exclude, you control for anything that you think might influence or selectively bias your perception of what this is. Okay? So again, carrying with this example, if you said, I want to do a survey of how many classrooms in the Department of Health Sciences have functioning, whatever they're called, laser pointers, okay? You're making an assumption that everybody knows what a laser pointer is, and you're making an assumption that all of them have more or less the same kind of functionality. In other words, if X isn't if X isn't working, the battery isn't working, then etc. So you have certain assumptions across the board in terms of the reality you're trying to measure, and that allows you to proceed with a specific set of methods. You cannot get into anything that would influence how this pointer is being used, where it's being used, who's using it, who gets to use it more than others, is considered a contextual influence on whether these things are functional or not, and you would try to control for it. Okay, I know this is not the best example, but I will figure some other ones out. So the instruments are standardized, and you're emphasizing generalizability and reliability. So in other words, if 5 of you selected did the same piece of research, you should come up with exactly the same results. Okay? There's no room for subjective interpretation. So these are some questions in HPSR which would rely on a positivist approach, or could. Is the policy or intervention cost effective? Why does that sound like a positivist approach to you? Or why could it be addressed through a positivist strategy? What do you do in a cost effectiveness study? Yeah?
Right, so you can measure the input and output, like whether the amount of input is giving you the correct amount of output. Mm-hmm. So it's something that's measurable objectively. Mm-hmm. So maybe that's why it's positivist.
Okay, so a cost effectiveness study assumes that for my intervention, I should be able to capture the reality of all the inputs, as you said, that are required for that intervention. So the training, the materials, the staff costs, the infrastructural costs, I should be able to capture that objectively. And I should also be able to capture the information on costs, how much they cost, and there should be a measure of effectiveness as well, which is introducing a training intervention is a complex intervention, which is why it's more difficult to do it through a positivist approach. But if we're looking at something which is a bit more straightforward, where the costs are relatively easy to measure, and the effectiveness is also relatively easy to measure, then you would say, okay, I can do this through this approach. What is the quality of care in X ward? Okay? Now, per se, the question isn't necessarily a question that should be answered through a positivist approach, but you can, okay? How do you make this a positivist question? You set the boundaries of exactly what you mean by quality, okay? Completely fixed, so that, as I said, 4 or 5 different people, researchers among you would use the same standardized tool to measure quality, okay? But just by looking at the question doesn't tell you whether this is positivist or not. It's the approach. Yeah? So as soon as you predefine, the researcher predefines what they're measuring and standardizes the approach and says that the approach that's going to be taken is a reliable approach, it's something that's been tested before, etc., then you're moving into a positivist approach because you're assuming that the measurement that you're using is not biased by any subjective interpretation of the person who's administering the instrument. Okay, that's very different from a relativist or a social constructivist approach. Sorry, there's something missing up there. Social constructivism should be. So here, the idea is that your social reality, or your reality in general, is cohesive and ordered, but it is apprehended subjectively. So in terms of the ontology, what is the reality? Let's go back to our example of the stress in the A&M, not A&M, the ASHA workers, okay? A positivist comes up with a scale, and they say, okay, I've got 4 things that I'm going to look at stress. I'm going to look at fatigue, lack of concentration, some kind of mental health effects, etc. But each of those items is going to be categorized in a way that can be measured the same across the board. So I apply this tool, and I'm basically predefining how I measure stress. Okay? In this case, we're not using a standardized, predefined tool. We're assuming that the reality of stress cannot be known through a tool. We can only know it if we ask people themselves about what stress means to them. So the reality is a subjective reality. It exists, but it exists differently for different ashas. Okay? And it focuses this social constructivist perspective, which underpins most of the social sciences in terms of the research, but there's also positivist approaches used in the social sciences, but is that it focuses on how individuals themselves make sense of the world through their perceptions, their feelings, their emotions, the meanings that are attached to a particular construct, which means that there could be multiple realities, because you conduct interviews to understand what stress means for ASHA workers in different states, or for older and younger, or for whatever, and you're going to get lots of different ideas about stress. You're going to get a very interesting, probably, understanding that stress means different things to different people. It has different consequences for different people, right? So this approach is really centered on meaning and what do things mean in context. Because you really want to understand how the context of the workplace, the work burden, the family life, how all those contextual factors might influence how that person defines and experiences the stress. Okay? Your methods in this case are not standardized. They are open-ended, they're flexible, and they're centered on this experience of reality, which shifts according to who you speak to. So examples here, how do patients experience a new quality of care initiative? So in the positivist approach, we said, what is the quality of care here? And we said we could approach that in a very standardized way, or we could sort of ask people, what does quality of care mean to you? And do you think this health center offers you good quality of care? And again, you're going to get a lot of different responses, because for some people, quality of care means the provider was very friendly, or the provider was wearing a white lab coat, which was very clean. Yeah? You get all kinds of things. And here's another example. What's the impact of gendered power dynamics on nurse-doctor relations in this clinic? Okay? Your construct here is gendered power dynamics. But what this means in that context, we don't know yet. Okay? So we're going to try to approach it through a constructivist. Okay? So relativist and constructivist means the same thing. You can stick with social constructionism if you like. But in principle, relativist just refers to the fact that the reality is relative to your person. It is not so relative as opposed to fixed. Okay, any questions on that? I think this will you be familiar probably from your training already. Okay. The third paradigm we're looking at in health policy and systems research is something called realism. And this is a paradigm that is kind of in between positivist and constructivist. So here they're saying that the ontology, the reality I'm capturing, is independent of the observer, but both the natural and the social worlds are real. Yeah? And knowing reality through science is always relative to researchers' positions and their perceptions. But this is an approach that is often taken for explanatory studies. So where you're trying to build a theory about why something is happening in the health system. So very often you will have heard of realist reviews or realist evaluation or realist approaches. And basically you're often looking at issues of causality and mechanisms. So how is this intervention working in this particular setting? For whom is it working? Why does it work in this setting but not in this setting? Yeah? And in what circumstance does my intervention work? So it's very helpful in terms of making sense of interventions and programs that are complex and that have outcomes that are context dependent. So we'll be taking an entire session of study design looking at approaches, realist approaches, in evaluation, because evaluation science, where you're evaluating an intervention, often or could work with a realist approach. So your types of questions are how or why does this intervention work or not work under specific contextual factors? Yeah, because that's usually very interesting, is that you implement something across the country, but you notice they're doing much better in Maharashtra than in Madhya Pradesh. Why is that? What are the contextual issues? What are the mechanisms that make the intervention work in this setting but not in this setting? Yeah? So how and why do pay-for-performance programs implemented in low and middle income countries result in intended or unintended outcomes? Okay? So it's very often focused on an intervention, and I'm saying intervention in the broadest understanding of the term. Yeah, because an intervention can be as simple as introducing a new waiting room. Yeah? You might not think of it as an intervention, but it is an intervention, because by introducing a new waiting room, you create all kinds of new dynamics. And it's not just about moving people into the waiting space, it's whether they want to sit in that waiting space. So I'll just give you an interesting example. In South Africa, in that project that we were looking at in infection prevention control, one of the interventions suggested was to create outdoor waiting spaces, because it would be much better in terms of ventilation. It's a hot country, you could have a nice shaded area. And actually, later when they did some of the qualitative work, they found that people hated the idea of outdoor waiting spaces. Why? Because they felt that everybody who had to sit outdoors was made to feel that they were somehow lower in terms of social status than the ones that got to sit indoors. So we would have never anticipated that, right? That actually the place where you wait in a health center may be associated with, your perception of your worth, your social worth in the system and how you're treated by the system. So if you're made to wait outside, there must be something, they don't want me inside the facility because they think I'm whatever, low caste, low class, already sick, etc. So that's just an example of where a simple thing like that, we needed to do that kind of research to see why is this not something that's acceptable. Okay, and your last paradigm that we're going to talk about is a so-called activist paradigm. Yeah, so this is the starting point for an activist paradigm. Is that reality exists, yes, there's a measurable reality, but it has been shaped or skewed. Skewed means biased, yeah, by cultural, political, ethnic, gender, religious factors which create inherently unequal systems. So here there's a focus a lot on power hierarchies. Power is central to this type of research because you're trying to uncover injustices, unequal relations, inequities. And there's also a focus on sources of authoritative knowledge. So authoritative knowledge means we're trying to look at why it is that some types of science or some interventions or some groups are prioritized over others. Why does it become commonplace? Nobody questions it anymore. It's just the way it functions. And there's some very interesting work in India, especially in maternal health, I think, looking at how certain hierarchies, gender hierarchies, and caste hierarchies become implicit to the internal bureaucratic systems. And it's something nobody blinks an eyelid here because it's so much part of daily life. But when you look at it from the outside and you say, well, what's going on here? Why did it take so much longer here? Why is there so many delays here? And you understand it as a function of inequalities that are often implicit, not explicit. Then you can adopt a more critical stance on how you would change those things. So this kind of research is explicitly used to uncover power imbalances, inequalities, and to inform social change. And the approaches designed to collect data are often trying very hard to not only to impact participants, but to change systems, but also to incorporate participants in the research. So Solomon and I will do a session on participatory action approaches, which to some extent take on a more activist approach. Not all of participatory research is necessarily activist, but a lot of it is, because the idea is that you cannot do things to communities without them, right? So examples of questions are, what are the social processes, the structural factors, including power relations, that explain differences in people's access to or experience of the intervention? Okay? And the assumption is when you see that there are differences in terms of uptake of an intervention, the activist is always going to be looking at the power issues behind that. Okay, so I'm going to take you through a couple of papers where I want you, it's going to be a bit strenuous because you're going to have to read online, which is never very fun, but I want you to try to think about what paradigm you think informs the research and where do you see this. Okay, so remember we have positivist, we've got social constructivist, we have realist, and we've got activist. Okay? All right. Okay, this paper is called The Social Context of Tuberculosis Treatment in Urban Risk Groups in the United Kingdom, a qualitative interview study. So I want you to briefly look through the text. This is just the abstract. And then I'm going to pick on a table, a particular table, and I'm going to ask you what you think, what research paradigm underlines this study and why. Where do you see that? I'll give you just a minute or so to look through, to scan actually. Okay, so this table, what do you think it is? First of all, what is the reality they're trying to capture?
So the study was aimed to capture the experiences of tuberculosis treatment in...
Good, okay. Experiences of tuberculosis treatment.
Yes.
Everybody agreed? That's the thing, that the reality they're trying to capture, okay? What do you think the paradigm is here?
I think so it's positivism.
Positivism.
Yeah, the first
Why?
one. My colleague is thinking it's relativism, but I thought we can actually measure, like the studies aim to describe the social context of adherence to treatment, so they can measure who are following adherence to
but
that.
read through
and
the
not.
methods. Read through the methods, okay, before you say it's positivist. I'm not arguing with you, but I'm just saying make sure you look through carefully. Yeah?
Yeah, I haven't read everything, but yes.
Okay. Experiences of TB treatment. Anybody else? Anybody disagree that this is a positivist study? Yeah?
I think because it's focusing on individual experiences of the, yeah, so maybe it has a relativist approach because
Okay.
it's focusing on individual experiences of patients with receiving the treatment.
Okay. Can you, when you look through the sections of the abstract, are there other things that jump out at you that make you think this is relativist or this is positivist? Go ahead, Shivani.
I think it is activist because it has, there are social it is looking at the social structures
Okay, where do you see that?
in the methods.
And where else?
And in the aim of the studies also to
Okay.
describe the social context of the institute treatment.
Okay. Okay. So far we have positivist, we have positivist, relativist, and realist. Anybody want to suggest that this is activist? I mean, a realist, sorry. Okay, what does this table think? What do you guys think? Okay, this is very, very important to be able to do, yeah, because when you read, you've got to be conscious about what is this study being informed by? How are they measuring their reality? Yeah? Okay? It's actually a combination, I would say. I would agree with you that it's a relativist, but there is some activist element somewhere, okay? So we need to find it in the abstract, yeah? Where do we see it? Where do you see it? Look at the objectives. What gives you a clue? Okay, what are the words that jump out at you?
If we look at
Yeah?
the methods, it's a qualitative cross-sectional study.
Okay.
Like that's one point where and other thing, like if you go to the conclusion, like it is like the conclusion is saying is need for integrated care across the drug, alcohol, HIV, and homeless something. So it makes like we cannot put this into any single, like it's a reality, like what is that made me to think like that.
Okay. Okay, good. So in the objectives, there is something jumping out at you. Experience, exactly. What else? Social context, okay? Those are your buzzwords, yeah? What about in the methods? You already mentioned qualitative. What else? Semi-structured and? The role of broader social structures in shaping health actions, yeah? In the results, do we notice anything? Yes, we do actually. We notice what you said, Shivani, the more activist bent. Why do you see some kind of an activist paradigm underpinning this? Go ahead. What do you see there? In the results.
Could it be social and institutional barriers to adherence?
Oh, sorry, who's saying that? Yeah. Okay. Complex medical and social needs. So this still, you can say, well, doesn't necessarily tell me it's an activist study. You could measure that in a positivist way. But I think when you get to this part, participants receiving DOT reported negative and positive experience, reflecting the type of DOT provider and culture of the organization. Culture of the organization. So that's another interesting thing that they're looking at. They're saying the culture of the organization influences people's experience of treatment. Okay, another clue. In terms of your conclusions, I think what's interesting here is complexity, social needs, and I think what you already mentioned, this issue of looking at integrated care. So it's not directly starting from an activist starting point, but somehow implicitly we feel that this person is concerned with social deprivation and its impact on people's ability to stay on treatment. And actually the conclusions are very much driving a more, a way to address this in a social way, as opposed to just saying, no, monitor them more. Monitor their treatment more. Watch them by video. Okay, it's a very different approach to saying integrate services for homelessness, alcohol addiction, etc. Okay? Experiences, social context, broader social structures, culture of the organization, and so on. Okay? So think about this when you look at a paper, always, even just looking at the abstract, you should be able to identify the paradigm. All right? Next one. Okay, so the First Nations people refers to Indigenous people in Canada. Yeah? Okay, this table, what do you think? What is the reality that's being measured? How is the reality being assessed? Sorry, I know this is not so easy, but we have to get through it. Sorry. What stands out as something that's unusual about this paper? Anything? You go ahead, just say something. Don't worry about it, even if it's off track, don't worry about it.
Analysis from the past and current
exactly.
treatment
exactly.
scenario.
Okay, so there's something about historicity. Okay, we're not sure what it means, but when we look a little bit more into it, we realize they're talking about historical experiences of TB care, which are impacting on current behaviors. Okay, so what kind of study do you think it is? What's the paradigm? Okay, remember, is it a positivist study? Anybody think it's a positivist study? No. Okay. Is it a constructivist study or relativist study? It could be. It could be because they're using interviews, right? They're asking about experience. So that makes it a constructivist study because you're asking about what is your reality of TB treatment, okay? Is it an activist study? No, you're shaking your head. I would disagree with you. What is the premise here? What is the starting point?
Historic.
Attempts to eliminate TB among First Nations peoples in Canada must address historical legacy. Understanding the contemporary effects of treatment can be seen as part of a larger project of truth and reconciliation. So the researcher is starting with the point of view that First Nations people in Canada are very disadvantaged with regards to their experiences of TB treatment in the past. They were forcibly removed from their communities. They were moved into the urban areas, into TB sanatoria, and that was traumatizing for them. And it had a lasting effect because now there is not much trust or faith in the current day services because of this historical legacy. So that's an activist starting point because you're pointing to an injustice from the start. Okay? Or just explain to me why you would disagree.
I could think because the 2-3 things which I could make out that it could be a critical realistic because first of all in the second line only they're trying to say that they are trying to explore the functions and building it with the historically and what is the current infectious, and then in the later paragraphs he's talking about they're trying to build a mechanism also. So I thought that it could be a critical realism.
Interesting. I never thought of that. Very interesting point. Okay, that's something I probably missed completely, but you've raised something very fascinating, which is that actually the objective is to explore the function of talking about the past, which is an activist. The activist starting point is looking at First Nations people as disadvantaged, yeah? But the realist thing you're suggesting is maybe there's something here about saying there's a larger project of truth and reconciliation. And by getting people to talk openly about what happened to them in the past can maybe shed light on the, you know, the historical inequities. So possibly there's an element of realist study. I'm not sure I see it yet. I would have to look at the full paper, but I like that input. It's really good. Okay? All right, I'm sorry we have to get to 2 more, and then I will release you, and I promise you it won't be so excruciating. Okay, historical statements is your clue. Historicity. Ongoing failure to eliminate TB from First Nations communities gives you a clue that this is an activist stance. And the larger project of truth and reconciliation is also a clue that this is an activist, but maybe potentially. Usually a realist thing is about a specific intervention, so we would have to see if this paper actually documents whether this kind of intervention of speaking about the past made a difference. I'm not sure it does, actually, in this paper. Okay, last one. Patients with tuberculosis experience difficulties in accessing diagnosis and treatment. Patient pathway analysis identifies mismatches between TB patient care-seeking patterns and service coverage, and so on. We developed an algorithmic approach to analyze and interpret patient-level routine data, etc., etc. We constructed 7,255 pathways for 6,258 patients, and so on. And they're reporting on their results in quantitative terms, longitudinal analysis of routine healthcare data. What kind of study? Last group? Positivist? Not, be careful, don't say positive. Positivist, yeah? If you say it's a positive study, nobody's going to know what you mean. Positive, negative? No, it's positivist, okay? Constructivist, realist. Okay, why is it positivist? Okay, I want somebody else in that group to speak. Lady in yellow. So very, very clear indication that this is a positivist study. Where do you see it? Anybody in that group? I know it's difficult to read through a text on screen. I'm sorry for that. Okay, so there's something that you should see in the methods and the results which help you see that it's a positivist study. You're nodding, so why don't you tell me what you think it is? What is it? You're definitely nodding. I definitely saw you nodding, so you must be able to tell me what it is. Mm-hmm. Okay, so what is being measured? What is the reality that's being measured? Not sure about treatment outcomes. Is it treatment outcomes? Yes, it's pathways, right? So it's different things along the pathway. Yeah, good. And what else? What else tells you it's positivist? Look at the method.
Heterogeneity in pathway patterns.
Mm-hmm. Okay, but what's the method? What's the source for their study? Where is it? We analyzed 1 million patient records in the Taiwanese National Health Insurance database. Okay, that's your source of data. It's positivist. Positivist, why? Because it's a way of quantitatively assessing the reality of whether people have TB or not, and you're constructing on the basis of this quantitative secondary data pathways. Okay? So, patient pathway analysis, it sounds qualitative, but in this case it's quantitative. Random sample of 1 million patient records, also gives you a clue. Constructed pathways, I mean, can you imagine doing qualitative work? Constructivist work with 7,255 patients? No. So the numbers also give you a clue. Yeah? Okay, good. I will spare you the anxiety of going through this one, but I'm going to tell you this is an example of a realist study, this last one. So look carefully at it. So despite progress towards NTB strategy for reducing TB incidence and deaths, South Africa remains among the top 10 high burden. Large challenge relies in how policies to improve detection, diagnosis, and treatment completion interact with drivers. So now look at the methods. Theory building case study design, using context and implementation of complex interventions framework to identify contextual determinants of the problems in TB care. That's your clue. Yeah, it's a theory building study. They're trying to identify what are the contextual determinants that influence certain outcomes. They used mixed methods, and if you look at the results, delayed diagnosis caused by interactions between fragmented healthcare provision, limited resources, verticalized care. So they're pointing to a number of systemic mechanisms. Yeah, and in the conclusion, let's see. There's nothing there necessarily, but basically this is your clue here. Okay, and maybe this is also a bit, data was inductively analyzed and mapped onto 7 context implementation, whatever those CI contextual domains were. Okay, and TB policy needs to resolve tensions. So I appreciate this is a challenging exercise for you, right? That's completely normal. This is no class gets this like right off the bat. We also had to race through these different paradigms. But this is something that I really would encourage thinking, okay? I can share either the papers. I'm not sure the papers will make that much of a difference. But think about those 3 things. What is the reality that I'm trying to capture? What is the construct I'm trying to assess? Either quantitatively or qualitatively or whatever I'm trying to do. What is it? Is it stress? Is it TB outcomes? Is it TB treatment? Is it adherence? Is it some kind of systems issue? And then think about how will I know what I know? So what is my approach to assessing that reality? And then you look at the methods. So those are the 3 critical things that belong to a paradigm. Okay, this is yet another one, but this is another realist study where they used a realist review to examine how complex socioeconomic interventions for TB treatment and care were defined. But maybe we can give you this as homework. I'm going to give you these 5 again just to look over. Okay? Good. Okay, I think we're going to stop there because we're going to move into another small exercise where you get a chance to do this in a bit more detail. I've got to check whether we have the time to do it, but I think we can stop with the lecture part of this if that's okay. Brilliant.